Hospital and Holy Family Hospital, Mumbai. I have the pleasure and honor of having two stalwarts in the field of hypertension. One is on my right is Dr. Venkata S. Rahm. He is the President and CEO of the Medicity Hospitals, Hyderabad, and President of the Board of Governors of the American Society of Hypertension. He has had an immense contribution in the field of hypertension, both from the US and in India. And we look forward to an interesting chat with him. And on my left is Colonel Dr. Chopra, past President of CSI, also a great contributor in the field of hypertension. And so we start the ball rolling with a question to Dr. Venkata Rahm. Dr. Rahm, we start with something very fundamental, the measurement of blood pressure. Now we know that the correct way of taking the office blood pressure is well laid out, all the precautions that have to be taken, we all know. But the question I want to ask is, in the office, given that you are taking the blood pressure correctly, how many times do you take the blood pressure, or what is your advice? And at what intervals do you take the blood pressure? And after taking 2 or 3 or whatever you would like to advise, you take the average or you ignore the first 1 or 2 readings? What is your advice?
Thank you, Akshay, and greetings to Dr. H.K. Chopra also, and all the best wishes to the audience. Akshay has asked a very fundamental question. And actually, my former colleague, Dr. Norman Kaplan, stated that one of the most important things that you do as a doctor is to measure the blood pressure. And then he also said that one of the sloppiest things that you do as a doctor is measuring the blood pressure. So that says it all. As Dr. Mehta has mentioned, that the entire evaluation and management depends on the accuracy of blood pressure measurement. For over 100 years, we were following a sphygmomanometer with mercury, measuring Korotkoff sounds, hearing, and calling it systolic, diastolic. It has served us well for a long time, and many of the clinical studies were done utilizing this technique. But what has happened is unfortunately this technique that we do is very simple, is not reproducible and fraught with many errors. So more recent guidelines do suggest to take the blood pressure with digital technology rather than manual blood pressure. Manual blood pressure measurements are eroding rapidly, and there is also a Government of India order against using mercury in clinical practice. So there is a Government of India order, and there are new guidelines suggesting that one should use digital measurement of blood pressure with automated devices. At the present time, Akshay, I can say with confidence, almost all the digital techniques are validated, and there should not be any suspicion about the accuracy that we used to have until 5 years ago. If you had asked me 5 years ago, I probably would have been somewhat skeptical. Now the instrumentation and the approval of the instrument by the Government of India, TCGI, is all standardized. So I could say that almost all the digital blood pressure measurement machines are reasonably accurate unless you have a reason to suspect it. So the proper way of measuring blood pressure now, I would strongly recommend, would be with a digital blood pressure which is automated, which comes with a cuff. It records systolic and diastolic, and one would take the blood pressure, if possible, about 3 times 5 minutes apart. And that is, if possible, I say it, because in clinical practice, it is not possible the way we talk in the surroundings or when we talk in conferences. In clinical practice, 50 or 100 patients are waiting for you, and you don't have the luxury of dedicating 20 minutes. What I suggest is, as much as possible, try to use automated digital. If you use it at least about 2 to 3 minutes apart, that is good enough. And the second reading is preferable over the first reading. Ideally, 3 is recommended, but I don't think that it is possible. So let me summarize then, Akshay and others. One should try to take the blood pressure with automated device as much as possible and use that as the guide to diagnose and treat hypertension.
Right. Anything else you would like to add?
I think Dr. Venkata has just mentioned very, very meticulously.
Correct.
That the blood pressure measurement is an art.
Right.
It's not only a science. And what he said, that we must ensure that the doctor who is taking the blood pressure is equally comfortable as the patient.
Yes.
Sometimes I've seen the doctors are great in a hurry.
Right.
And they don't have time to take the blood pressure. And mostly in India, it happens that the blood pressure is checked by nursing staff or by a paramedical staff or by junior resident who commit a lot of mistakes. If you want to know the correct blood pressure, we must ensure the proper ambience in the room, proper temperature in the room, the person has not consumed adequate amount of coffee, he is not anxious, he is not in anxiety. I think all these factors are very important to measure the accurate blood pressure, as already mentioned by Dr. Venkata.
One more advantage what I have seen of the digital instruments, they can give you a mean reading without you calculating. There is another thing the Europeans or the British people have just kind of suggested, that if you have 3 readings and the difference between the readings is too high, that means the first reading is very high and second, thirds are low, there is a suggestion that these people, this could be predictive of white coat hypertension.
Yes.
Is that true? Okay.
Yes, that is true. If the blood pressure varies significantly in the office from same visit quite a bit and the first reading is very high, they could have this phenomenon of white coat effect. In this context, Akshay, I want to mention something which is amazing in India. Of all the countries, India is able to embrace the medical technology much faster than many countries. Many countries like North America and Europe talk about it, but in reality, India is one country that embraces medical technology very fast. I can tell you in my own experience, this could be only limited to cities, I know it, but there are new machines that are now available that take the blood pressure automatically 3 times, and then digital printout will come, and that printout can be with the patient as a guide. They can see you or they can see somebody. So I think more and more digital technology has to be used. I know that some people don't believe it, but on the other hand, you have to accept the scientific advances.
Okay. And you think we can use this digital technology for home readings? Of course, we know we take it at daytime, but can they be used for taking night readings also? I mean, I know ambulatory blood pressure measurement is possible, but if that is not possible, are these machines can be used for night reading? Say you go to sleep and program them?
No, very good question. That is the drawback of any measurement manually.
Okay.
Which is digital is also manual because you're inflating the cuff.
Correct.
Is that this is not a substitute
possible
to ABP.
ABP. Okay. Now we come to the big everything in the blood pressure is controversial. So the other thing is the definition of blood pressure. The American guidelines and the European guidelines. What do we follow? Are they really different or they appear different but more or less the same? So 130 by 80 is the cutoff or 140 by 90 is the cutoff. So what is your take on that?
Okay, I will comment on it. India has a population of 1.3 billion.
Right.
And it is estimated when you combine rural and urban together, it is estimated 30% of Indian adults have elevated blood pressure, and the implications of untreated high blood pressure on India are enormous because of the country's size, 1.3 billion people. It has been estimated that annually we spend $24 billion in managing cardiovascular disease, which means $2 billion monthly, and this is a figure that came to us from ASSOCHAM, with which Dr. H.K. Chopra has been associated with. So ladies and gentlemen, this is enormous burden on cardiovascular disease, management, disability, loss of income, stroke, end-stage kidney disease, dialysis, etc., which are very expensive. Compared to the expense of treating disease, prevention of the disease is much better, because medicines in India are not that expensive. Dialysis is expensive, bypass surgery is expensive, angioplasty is expensive, stroke management is expensive. Right. So we can prevent this from appropriate preventive cardiology. Now the guidelines, as you have mentioned, American guidelines have downgraded the definition of high blood pressure to 130/80 and above. European guidelines have kept the previous definition of 140/90, and these two guidelines are now the latest guidelines, and I don't think we'll have any new guidelines from globally for the next 10 to 15 years. I think the era of definition of hypertension has come to a stop with these guidelines. So there is a difference of 10 millimeters mercury between European guidelines and American guidelines, but the goal blood pressure that is recommended by both the guidelines is the same. Less than 130/80. The question that is often asked of me and Dr. Chopra and of you also is whether these guidelines are applicable to India. I mentioned yesterday that hypertension is a hemodynamic abnormality. It does not depend on your zip code, where you work or where you live. It does not depend on your PIN code where you work. If there are certain PIN codes in the country where there is no blood pressure, I would like to migrate there. So most important thing is, it does not matter whether you live in India or Uzbekistan or US or Sri Lanka or Myanmar. Right. Blood pressure is blood pressure. So the most important thing for us is to accept that wherever you live, you are subject to manifestations of high blood pressure, and Indians are much more susceptible to cardiovascular complications from hypertension. And you mentioned European guidelines. European guidelines have identified South Asians as a high-risk category of complications from hypertension by 40%. So at the same level of blood pressure, South Asians are at a 40% higher risk. By South Asians, ladies and gentlemen, don't be fooled that they are talking about Pakistan or Bangladesh or Sri Lanka or Nepal. They are talking about India. When people say South Asia, it is a code word for India because it has got a large population. And Europeans have also identified high uric acid as an additional risk factor in patients with hypertension. And there are data now from India, from your own wonderful city of Mumbai, showing that the incidence of hyperuricemia in Indians is very, very high. So based upon the new guidelines, they have actually identified Indians as a high-risk category of patients. So I don't think one should argue whether these data are applicable to India. They are eminently applicable to India, right, based upon this. And myself and Dr. H.K. Chopra have written an editorial for circulation, which is going to come now, that the ultimate beneficiary of the American and European guidelines is India. In fact, we have, our concluding sentence was, India is a receptacle of the new guidelines.
So I think that's a very important take-home message, that though the thresholds or the definitions are different, the target is the same. For example, from the American guidelines, if a person has 130/80 but is a low-risk patient, lifestyle.
Right.
And if it's high risk, then treat. European guidelines, even if it is less than 140/90, if it is high-risk patient like South Asians, better to treat. So the target is the same for both. It is only the definition which is different. But taking from there, supposing you have a low-risk patient, a very normal-looking person, no risk factors, no family history, 40-year-old, 35-year-old, and his blood pressure is 134/84. Is labeling him a hypertensive going to affect him in the future? Putting a label on him, oh, he was okay, but now I'm hypertensive? Or should we not label him and just advise him maybe?
Sure, thank you very much, and I think HK will also comment on it.
Yes.
In fact, this has come when the new goals and new definition of hypertension has been proposed. One of the things, as Akshay, as you have mentioned, is the psychological impact of converting a person into a patient.
Yes.
For no fault of his.
Yes.
You go to sleep one day as normotensive, and next day you wake up as hypertensive because new guidelines have come the night before. So suddenly a person has become a patient.
Right.
But we have to accept it.
Right.
We have to accept the way we have downgraded diabetes definition, the way we have downgraded hyperlipidemia, the way we have downgraded BMI. We have to accept it. The feeling is there could be a psychological impact of it, but the benefit is by early detection and management, the long-term benefits are overwhelming. You are absolutely correct calling somebody hypertensive, but we have to accept hypertension is a phenomenon that is unavoidable in some families. You can't do about it. But we have to manage it and we have to accept it. And of course, the first step, all the guidelines recommend lifestyle changes. In fact, from a pharmacoeconomic point of view, the estimation is that if you follow the guideline definition of aggressive treatment, if you follow the definition of lifestyle changes, the increase in pharmacological treatment will only be 10%.
Okay.
The increase will only be 10%.
Oh.
Not the way that everybody is taking it. So very, very important. One comment I want to make for our public and for all of us is that when you increase the number of people who are eligible for treatment,
right,
who are eligible for treatment, it is a public health burden. But if you increase the number of people who are diseased, morbidity, the burden is much greater. You have people who are surviving stroke that is more difficult to treat than prevention of stroke.
Right.
And this is very, very important. The way, for example, in your own wonderful city of Mumbai, you see how the traffic has increased in the last 10-15 years.
Oh, yes.
But you are managing it.
Yes.
And you see how many flights are there in the sky, increased, but you are managing it. So the demand has increased, but you have to manage it.
Right.
And 1.3 billion people, their requirements for water and milk have increased.
Right.
But we are managing it.
Correct.
We are not running away from it. So suddenly you increase the number of people with hypertension, you manage it, and you don't run away from it.
That's very nice.
I think it's very wonderful. I think I totally agree with Professor Venkata Rahm. Akshay, you asked a very good question. I personally feel that India is the world capital of diabetes. India is the world capital of hypertension. India is the world capital of obesity. And India is the world capital of many diseases like hypothyroid, like inappropriate consumption of NSAIDs. And we see a lot of people consume oral contraceptive pills. They take steroids. And there is no proper control of blood pressure at all.
Right.
India is highly vulnerable. I personally feel that hypertension is like every day's tsunami in India.
Wow.
It's very unbearable.
Right.
I remember the words of Dr. Venkata Rahm when he came to Delhi. He gave a very nice nomenclature to hypertension. And I think Dr. Venkata Rahm remains now. He said that hypertension is like a hemodynamic malignancy, which is true. The reason is nobody knows who is going to be a victim of hypertension and infected complications. They come to us with epistaxis, they come to us with a stroke, they come to us with MI, they come to us with CKD.
Right.
And I think it is the number of blood pressure which is very, very important. Dr. Venkata Ram's emphasis was that we must ensure lower the better. Right. And I totally agree. Whether it's in AHA or ACC, lower the number, higher will be the longevity, good will be the prognosis, and less will be the morbidity and less will be the mortality.
Right.
Whatever method we use. And I personally feel, which again I discussed many times with Venkat on many occasions, that CBPM or OBPM is not the answer.
Right.
It's the ABPM.
Right.
After the age of 40, I feel in India, everybody needs at least every yearly ABPM.
One ABPM.
And every 6 monthly in resistant hypertension.
Right.
Resistant hypertension is very, very common in India.
Right.
I just quoted yesterday in a data I was presenting a Spanish resistant hypertension trial and registry where they mentioned that if we take the prevalence rate of resistant hypertension by CBPM, it is 12.3%. But the same thing, same patients, if we take the prevalence of resistant hypertension by ABPM, it jumps to 64%. From 12.3 to 64% in a place like Spain, Spanish registry.
Does it mean there are so many masked hypertension people?
Absolutely.
Oh.
So many masked, so many have underlying white coat hypertension,
Right.
so many are undetected. So I think a time has come that we must ensure what is the exact burden of uncontrolled hypertension,
Right.
what is the exact burden of resistant hypertension, and how meticulously we must manage them.
Right.
We do not know in India.
Correct.
I think Venkata also gave a very nice statement yesterday. They don't think reduction of blood pressure by 2 or 3 per day, millimeter of mercury per day will make a difference. Count it over a year. Count it over years.
Correct.
That was a beautiful word he expressed yesterday. I think the morbidity and the mortality of blood pressure is the overall burden of hemodynamic variation
Right.
of the blood pressure in the whole day. Just taking one reading will just
Is
give you
not
an idea,
Right.
but it is the tip of the iceberg.
Sure.
So it is the ABPM which give you a complete circadian variation of blood pressure, and we have an idea he or she is the candidate where the blood pressure is highest at night. What is the persistent rise of time elevation in the night?
Correct.
How much is the burden of so-called nocturnal
Nocturnal
non-dipper?
hypertension.
How many has reverse dipping? How many has extreme dipping?
Right.
What is the hyperbaric index? What is the double product? So I think if we meticulously manage them and correlate with various variables like PRA, plasma renin activity, or aldosterone renin ratio,
Right.
or echo variables, I personally feel echo has a tremendous boost in knowing the morbidity which is hypertension inflicted.
Right.
We did a lot of work. We find LA volume is increased, LV and LV filling pressures are increased, LV mass is increased,
Correct.
LV hypertrophy is increased, and there is a lot of comorbidity correlates. So I think hypertension should not be taken lightly.
Right.
It's a matter of great concern in India.
Correct.
And I personally feel, after working almost for last 45 years of my life, that hypertension is #1 silent killer,
Right.
which is misdiagnosed,
Yes.
underdiagnosed, mistreated, and undertreated. A time has come, we all have to act if we
Correct.
really want to reduce the morbidity and mortality. One more thing, Akshay, we are very lucky and very privileged that we have a person like Venkat with us.
Oh yes.
We are honored that he left USA and joined
came
us.
here, right.
India is very lucky
Absolutely.
that the real
Yes.
pioneer
Yes.
and the real experienced person is with
Yes,
us.
absolutely.
We should take advantage of every minute
Absolutely.
of our alliance with Venkat.
Correct. Since you mentioned this, the widespread incidence of hypertension being asymptomatic, can we replicate something what was done in the US, like the barber shops taking blood pressures? Can something be done, something like that over here?
Yeah, it can be done. It can be done and should be done. Akshay, is very good question. The only thing is in India, the patients are also, they want their doctor to
Oh,
tell
yeah.
them. You can have any healthcare provider, you can have the most experienced nurse
Right.
who is actually better than doctors in taking the BP, they still want to talk to the doctor. So there is a cultural barrier in
Okay.
India. Can you imagine a barber telling a person that you have high BP? Indians somehow we have a culture.
Yeah.
We have to break that culture barrier.
Okay.
If you break it, yes.
Okay. Okay.
Taking a clue,
yeah,
Akshay, I think it's
yeah.
very important, this point which you raised.
Culture.
We must create a kiosk for blood pressure measurement
Absolutely.
everywhere. What is happening in USA?
Right.
The time has come.
Right.
We must create a red alert on hypertension.
Correct.
If you really want to reduce the stroke, as mentioned by Venkat,
Yeah.
if you want to reduce the STEMI,
Yeah.
if you want to reduce ACS,
Correct.
if you want to reduce CKD, please control the blood pressure. That
And
is
you
the
can have a
message.
paramedical person rather than if you can't have a medical person.
The
But
message is
yeah.
control the blood pressure by
Right.
whatever best methods you
Correct.
can.
Yeah. One last question. Actually, we know that the lifestyle changes can affect blood pressure. exercise 5 millimeters, DASH diet 5 millimeters, maybe some meditation 5 millimeters. Has any study been done combining all these lifestyle factors? Or do you expect that the numbers will go down substantially if all factors are taken into consideration?
Akshay, you know the answer, that's why you have asked the question, which is fine, the prerogative of the host. There are studies showing that there is a synergy and additive effect of multiple lifestyle modalities. Low salt diet, weight reduction, exercise, you combine them, it is like combination therapy.
So how much do you reduce? Would it reduce the blood pressure?
12 to 6 millimeters of mercury,
Okay.
double digit. Okay. So combination therapy, you're talking about combination of lifestyle changes, has same effect as combination drug therapy. So if your lifestyle is just not one thing, you start the day and you end the day with that.
Right.
And one more comment I'll make since your last question is when you treat hypertension as doctors, I'm talking about doctors, don't fall into patients saying that it's a little bit of BP, chodo mujhe. Nobody says, I'll postpone the treatment for little bit of lung cancer, little bit of breast cancer, little bit of colon cancer. Patient will never forgive you if you say that. But patients negotiate with you, but don't fall into the negotiation because blood pressure does not disappear.
Akshay, is my last message. What I get a clue here in this discussion, a panel discussion today, that we must control the blood pressure.
Yes.
We must grow younger and live longer. The only method is if we control the blood pressure.
Right. I think that's a nice way to summarize it. And thank you very much.
Thank you.
Thank you. Thank you, Dr.
Thank you.
Thank you.
Very good.